Okay, we're going to go ahead and get started for the next session. The next session is going to focus on neurologic presentation of VHL. So this would be brain and spine primarily. And I'm going to speak first about treatment in adults, and Dr. Laura Perla, one of our pediatric neurosurgeons, will talk about treatment in children. So I just want to spend a couple of slides talking about our neurogenetic oncology program. So we put this program together about 12 years ago because we realized that patients such as VHL patients with these genetic disorders required really a multidisciplinary program. What we noticed is that many patients before that point were getting their care fractionated across many medical centers. They would get their eye exam done at center A and their MRI imaging for their brain at center B, and they're getting their abdominal treatments at center C. And this is before we had a lot of this electronic medical records. And so when you saw a patient and you had to collect the records, it was making a bunch of phone calls, waiting for reports to come in. So it was a challenge. So we thought it would be best to kind of formalize a very specific program that allowed a true multidisciplinary treatment for patients, because as all of you in the room that have VHL know, these genetic disorders can be highly complex. So this is typically our flyers for the program. We have a number of clinical faculty, about 20 faculty across about 7 different disciplines, all of which are able to manage VHL patients. They understand VHL, they see a lot of VHL patients, and they're excited to see the patients. So let's talk now about treatment of VHL in patients with neurological disorders. So the challenge with treating lesions in the brain and spine is VHL patients almost always have more than one. And if a patient has a scan because they're having symptoms and you find there's 5 hemangioblastomas in the cerebellum, which one's really causing the problem? Sometimes it's obvious. There's a big one and then a couple of tiny ones. Sometimes it's not so obvious. Also, which one of the hemangioblastomas is most likely to become the next symptomatic one? A lot of you have scans and you're feeling great right now. When you say you're asymptomatic, scan shows a couple of small hemangioblastomas. Which one is going to be the one that's going to cause the problem for you next? If there's a way to figure that out or estimate, maybe we can stay ahead of the game. What's the expectation for symptom resolution? Sometimes the symptoms are non-specific symptoms like headaches. Sometimes they're very specific symptoms that we can attribute to the lesion. But what's the expectation to get rid of the symptoms or improve the symptoms based on the type of treatment? What's the risk of treatment? And I always look at risks as kind of a bifurcated risk. What's the upfront risk of treatment? You're going to have surgery next month. What's the risk of that? But what the second part of the risk is, what is the impact of treatment over time? So a lot of times VHL patients need a number of procedures over their lifetimes, and each one of these procedures can take a little bit out of the patient. So how is that going to impact the patient in the long run? And then finally, we've heard some excellent speakers so far today talk about lesions in the abdomen. How does the treatment of the brain and spine factor in when you got a growing tumor, let's say in the brain, but you also got a pheochromocytoma going on in the abdomen? How do you manage that? Which one should be treated first? Is the order important? So there's no kind of hard and fast rules for treatment of hemangioblastomas in the brain in terms of surgical resection, but there's some general guidelines that I run through when I see a patient. So first of all, size. If there's only so much space inside the skull. Skull is a rigid box. Anything that's growing inside the skull just puts pressure on the brain. So at some point, if the lesion gets large enough, you're going to have pressure on the brain, you're going to start to develop symptoms. So certainly a larger tumor, when we think about 2 or 3 centimeters, we get concerned, especially if it's associated with symptoms. The greater the severity of the symptoms, the more we're concerned about something needing to be done urgently. In the spine, the spinal canal is much smaller. The spinal canal is about the thickness of your thumb, and so it doesn't take a large lesion in the spine to start causing neurologic symptoms. So a 1 centimeter lesion in the spine, like a quarter or a third of an inch, is actually pretty big when it comes to potentially putting pressure on the spine. We consider for treatment those hemangioblastomas that are causing symptoms. Particularly if the symptoms are severe, we've seen some patients have like swallowing difficulty, for example, if they have hemangioblastomas and cysts in their posterior fossa pushing on the brainstem. And speaking of cysts, a lot of times in VHL patients in the brain, it's not the actual solid tumor that can get them in trouble. It's actually the cyst associated with the tumor. My next slide, I'll show an example of that. And then the last criteria is how do you manage a hemangioblastoma that we think is likely to cause symptoms or cause problems in the future, let's say a year or two from now? Is it better to try to treat it now when it's smaller and the patient's not symptomatic, or wait and see if it grows? So this is a little bit of a challenge. There's some tumors that are kind of right on the cusp. It's getting to be the size that we're concerned about, but the patient's not quite symptomatic yet. Do you wait for the symptoms to occur, even if it may not happen for a while? Maybe waiting is a good option if we think it'll be a number of years before the patient's symptomatic. But if the patient's likely to be symptomatic in the next 6 months, maybe it might be better to treat now before the symptoms come on. So this is a patient of mine with a hemangioblastoma in the cerebellum. So you see the solid part of the tumor is white there, but there's a large cyst around it. So you can see the cyst is dramatically a larger volume than the actual solid portion of the tumor. And so this patient manifested with some balance problems and headaches. He's been going on for 3 to 6 months at work. This is a stoic guy. Didn't really get scanned until the patient symptoms got severe, and you can see there's significant pressure on the brain. This is a sagittal view of kind of a profile view. Here's the nose here. Again, you can see the tumor and the cyst. So this patient at this size, this is about a 3 centimeter cyst. So and he's symptomatic. So the treatment for this was surgery. So this is the post-op scan. You can see the tumor is resected. In addition to surgery, we have the option of using radiosurgery. And radiosurgery is a non-invasive treatment that uses very focused beams of radiation to target the tumor. And so there's a number of machines out there that deliver this. We use a machine called the CyberKnife. There's other machines called the Gamma Knife. There's linear accelerators. They all have the same basic principles in that they deliver a high precision beam of radiation to the target. So this is an example of what a CyberKnife is. The patient's treated on a table. There's a robot that moves around the patient and delivers the radiation. The radiation actually comes out of this structure here. It's called a linear accelerator. It directs and focuses the beam of radiation to the tumors. It involves real-time tracking of the patient. So we have imaging software that monitors the patient's position in real time. And if the patient were to move or wiggle a little bit, all that motion is detected for and compensated for. And you can deliver the radiation with, it's less than a millimeter of error, so it translates about 1/50th of an inch of targeting error. So even with patient motion. So how narrow is the radiation beams? This is gives you kind of a scale here. Erasers 5 millimeters, the tip of the pencil is 1 millimeter. So the smallest beams tend to be about 4 millimeter beams to target the lesion. So if you're going to use radiation to target a hemangioblastoma, there are certain types of tumors in the brain that we favor for radiation. And these are some of the categories here. First of all, we need to make sure it's well circumscribed. That means we need to be able to see the border of the tumor. So if you're going to target radiation, you better be sure that you can outline where the tumor ends and the brain starts. We don't want a tumor like the one I showed you that needed surgery, which is causing too much pressure on the brain. The radiation can take a year or two to kill the tumor. So if there's a lot of pressure on the brain and the patient's symptomatic, radiation is not going to work fast enough to treat the tumor. In some patients, they've already had a surgery and the tumor is starting to grow back, but it's still relatively small. Maybe that's a good opportunity to use radiation to just halt it in its tracks. It prevents the patient from needing a second surgery. There are some patients that have significant medical comorbidities. We talked about some of the abdominal issues. Some patients have other diseases that would make them high risk for surgery. So those are patients in which the radiosurgery is a good option. And we also like to do radiosurgery. We talk about how patients need multiple procedures over their lifetime. Wouldn't it be great if a lot of those procedures could be non-invasive? So this is something that when we see VHL patients, we always factor that in. A couple of examples here. This is a patient with a hemangioblastoma there in the cerebellum. And you can see it was 2 years later, that tumor was treated with radiation and stopped growing. And then 2 other tumors popped up in the meantime. This is emphasizes the importance of screening. So then we had to go ahead and treat those patients. How well does the radiation work? This is kind of a Kaplan-Meier curve over time. You can see that we follow the patients out for almost 15 years. And long term, you still get about 80% control of the tumor. So that's pretty good for long-term control of the tumors. This is actually a very important slide because this is 25 years ago, 1997. The very first spine tumor ever treated in the world on the CyberKnife was a hemangioblastoma in a VHL patient. Okay, and this is the tumor right there. It's behind C3. To surgically remove this tumor would require a pretty significant operative approach. A lot of bone drilling. You got to get through all the spine to get to the tumor. That's going to be a challenge. So we treated this with the radiosurgery using the CyberKnife, and you can see it shrunk. You can see a pretty dramatic shrinkage over time. So this was a landmark patient because it established that you could, number one, do radiosurgery in the spine, and number two, it established that just like we knew based on gamma knife data that radiation for hemangioblastomas in the brain worked very well, this demonstrated that it worked very well in the spine. One more example, this is a cross-section in the upper thoracic spine of a hemangioblastoma there. It's not very big, but again, the spinal canal is the thickness of your thumb, and so this was treated with radiosurgery, and you can see 3 years later, it's unchanged in size. When we look specifically at just the spine data, this is data that goes out now about 6 years. On the Kaplan-Meier curve, you see about 90% long-term control. And we've published this a couple of times, showing the evidence there. At Stanford, we have the largest series of radiosurgery patients with hemangioblastomas treated in the world. We've been doing it since that 1997 case. When I talk last about kind of how we focus on the whole patient, VHL patients we know are going to come in with often multiple issues going on simultaneously, and they're going to have multiple issues going forward. So the key is to think of the long-term roadmap when you're assessing patients with hemangioblastomas and VHL. It's not just what lesions they have in their brain spine now that are symptomatic, but what other ones are going to become problematic. We've talked about understanding the treatment risks. I think this is an important discussion to have with your physicians. Having a multidisciplinary team is important for that. And again, I want to emphasize that we want to ensure the optimal quality of life for patients, because VHL patients, it's a lifetime disease. We want to keep you as high functioning as possible, and that's more than just treating one lesion and then that's it. It's managing the whole patient. We have a comprehensive team. These are some of the doctors that are part of the team. I'm going to switch now and